start off with a brief introduction about you. So, where do you practice right now? What do you practice?
Okay. Hi, I'm Dr. Deepthi Morais. I'm an anesthesiologist in Apollo Children's Hospital, Kadar Khan Road. I work with children. Predominantly, we do pediatric anesthesia there. But apart from this, I have a special interest in cerebral palsy.
Okay. So, everybody completes MBBS and then chooses their stream where they want to specialize.
Correct.
So, what was your moment when you actually thought this is where I'm going to be practicing for my life?
So, while doing MBBS, we go through a rotation when as interns, you get to work with different specialties, which will help you choose your specialty as for your post-graduation course. Now anesthesiology is something that you don't usually get to rotate in. You can choose to try anesthesiology or you can choose radiology. So the main reason I chose anesthesiology because I thought life would be very easy. My mom is an anesthesiologist.
Okay.
She works for the government and she used to work an 8 to 12 job. She used to be back home every day at 12. One of the reasons I took anesthesiology was I thought that kind of relaxed life was the life that I was going to have.
Okay.
But it turned out it was exactly opposite all that. So that's how you choose a post-graduation. So I chose anesthesiology. I decided to specialize in pediatrics because I love working with children, and working with children is very different from working with adults. It gives you a different type of satisfaction. There's a different type of trust when it comes to children, which makes it all the more interesting and challenging, which is why I chose to do pediatric anesthesiology. Again, very few centers had pediatric anesthesiology and were exclusively pediatric hospitals. One of those hospitals is Apollo Children's Hospital, which I just started in 2010, and that is when I joined.
Alright. So, is life as expected after this when it comes to dealing with children or anesthesiology? How is the department? And you said you had certain perspectives before getting into this domain. So, has it changed now after 14 years of practice?
The working hours have definitely changed. This is definitely not an 8 to 12 job. But pediatric practice itself, pediatric anesthesia itself, even since the time I joined, has significantly improved over the years. There are a lot of advances. It has become so much safer for children, and there's a lot of monitoring improvements that have happened. The equipments have become better. The drugs, there are a lot of advancements in the drugs that are used during anesthesia. So yes, it has significantly improved from what it was even in 2010, what it was when I was studying to 2007 to 2010. Even since then, there's been a lot of improvement. Yes, significant advances.
Okay. So, whenever it comes to children, they're always accompanied by their parents, and
Yes.
That kind of creates an entire different kind of a pressure when it comes to operating or anesthesiology. They'll be asking too many questions because they feel the children cannot express. So, does that put a lot of pressure on the doctor?
No. So how this works is when there is a scheduled surgery, right? The parents bring the child and we do what is called a pre-anesthetic checkup. Now during the pre-anesthetic checkup, we spend a lot of time with the child and we learn about the child, we learn about the child's interests, we learn about the child's diseases, we learn about the comorbids, we call it, the other issues that the child is having. So the child may be coming for an appendectomy because of an inflamed appendix. But we may find out that the child has bronchial asthma or the child has a seizure disorder. So we need to know what are the other comorbids that come with this child, though appendicitis may be the primary reason why we are operating. When we anesthetize the child, we need to know the child as a whole, right? Because that will affect the type of drugs we give, the type of anesthesia we give. The type of pain management that we do, all that gets affected depending on the other comorbidities that come with the child. So we spend a lot of time with the child, but more importantly, we spend a lot of time with the parents. The child is very easy to reassure. The parents are very difficult to calm. But I understand, as a parent with a child, I know how anxious the parents feel when their child is going for a surgery. Now, parents are not even worried about surgery, they are more worried about anesthesia. Though anesthesia is what makes the surgery more comfortable, the general understanding is that anesthesia is unsafe. So we spend time, we explain to the parents what exactly we are going to do. If the child is of an understandable age, we explain to the child as well. You may be surprised to hear that children want to listen and children are very obedient and they will follow instructions very correctly. So if you tell them that yes, we are going to take you away from your mummy, we are going to go inside the operation theatre, we are going to hold a mask for you is what we tell them, and then we ask them, do you know how to blow a balloon? So most of them are very excited by it. So what happens with this balloon is we hold a mask and we allow the children to keep breathing this anesthetic gas and the children fall asleep.
Okay.
Now after they
So
sleep,
it's not injected.
so after they sleep, we put an IV line for the children. Now most of the time this is what we do, but there are certain cases where we cannot do this. What I was just talking to you about is called an inhalation induction technique.
Okay.
Now many children you can just do an inhalation induction technique. There are some children who are not fit for this kind of technique. Say they have a difficult airway, which is a nightmare for us, or if they have difficult IV lines, then we are scared to, it's not safe to give it to do an inhalation induction. Those special situations we have to hold the child and put an IV line, but otherwise we try not to prick the child when the child is awake. We use local creams, local anesthetic creams that take care of that area where you're going to put the needle, so the child doesn't feel the prick. This balloon thing, we talk to the child while they're falling asleep, they fall asleep, and it's a beautiful procedure. You can so comfortably put the IV line under a controlled environment with all the monitors and all doctors there available. So it makes it very easy for the child.
Is this a new procedure recently it has come?
No, it's been there for a long time.
Okay.
It takes a little longer than the usual thing because it's a bit of a drama. The child has to come. You have to talk so much to the child to calm the child down. What we do is we bring the child in with an iPad or a phone, and the child is watching a video. Sometimes you have the child watching the video and then falling asleep while still watching the video. So during anesthesia, it has also been proven that when the child comes inside the theatre comfortably, the anxiety and the pain that the child has post procedure is also significantly less. So we try and spend that time during the pre-op assessment, what we call the pre-anesthetic checkup. We try and spend that time for the child and the parents. We calm them, we reassure them. Most of the children come in smiling, but the parents are still crying outside. Not much we can do about that, but we let them know. We explain to them, yes.
So few things I was pretty keen on when you were talking. One is previously people knew about only anesthesia. Now you said pain management.
Yes.
So is that becoming a separate domain in itself, like pain management, the advancements in that? Because the word sounds very curious to know more on it.
So anesthesia was always anesthesiology and pain management. When you get the degree itself, you get a degree saying you specialize in anesthesiology and pain management. But nowadays pain management as an independent specialty itself is becoming very popular. But as an anesthesiologist, we practice pain management for the children or patients that have a procedure and need pain relief post procedure. There are some cases where you don't, there is no surgery itself, but the patients come with pain. Now because I work with children, we deal with pain management here in our hospital, but for adults also, people come with chronic pains, then they need different types of pain management, and that is taken care of separately. That can be done by an anesthesiologist, it can be done by some general physicians. There are certain courses that you can do to be a pain physician, but all anesthetists are already trained in pain management. One pain management can be like of different types. One is of course giving tablets, right? You can give oral medication, you can give syrups, you can give injections, but these all act in all parts of the body. Like whatever drug you take, there's a certain route that it has to take. It does not act like, say you have pain in your knee, the drug does not just go and act on the knee, it has effects everywhere else in your body. So over the years, regional pain management techniques have become very popular. So say that we're going to operate on the arm. Say the child has a fracture in the forearm, and you want to operate on the forearm. Now, for this kind of a fracture, we know that to repair a fracture is a very orthopedic procedures are very painful. Now, the surgeon is going to put a plate and screws for the child. Before the procedure, after we hold a mask and we put the child to sleep and everything, we usually do blocks. We block the area that is going to be operated on, so that this will involve a block somewhere near the shoulder. Now, when we give this block, from when the surgeon puts the incision, the child already has no pain. So technically you can keep the child awake, but because the situation is not so comfortable and the child may not want to lie down in in an operation theatre like that, we anesthetize the child. We give them very minimal anesthesia. We go ahead and do a block. We make sure that the child has no pain during the procedure. And how we monitor the pain during the procedures, we look at the screen, we look at the monitor, and this monitor will show like an increase in heart rate usually means that the child is having pain. There's some kind of stimulation there. So we adjust drugs accordingly. We go ahead with the procedure, and if the block is effective, we see like when the child wakes up, the child has no memory of the surgery and does not realize that the arm has been operated on. The first thing that the child feels is hunger, not really pain, not really anything else. So it's very nice to see when there's a big surgery done on the arm, there's been blood loss, there's been plate and then screws and all that, but the child comes out and the first thing that the child says is that they're hungry. So that's very satisfying for us to hear, and we've gone a long way.
So you were talking about anesthesia during an operation in theatre
Yes.
and outside. So you said anesthesia when not in a operation theatre or room.
Yes.
So what is the difference? And also anesthesia, is it only related to operating procedures, or is it otherwise also people use it for different medical reasons?
Okay. So anesthesia is predominantly used for surgeries. We want the patient to not have to not feel the procedure that is happening. Now, anesthesia can be done outside the operating room also. This is called, there's a term called NORA. It's an accepted word in our specialty. So this is, NORA stands for non-operating room anesthesia. So NORA procedures are for, NORA is for procedures that involve say like procedures where you don't want the patient to move, right? So I'll give you an example. So say you need to do an MRI. I don't know if you've had an MRI before. Did you ever find the MRI comfortable?
Little suffocating
Yeah.
kind of a feel.
So
Claustrophobic.
Correct. It's a very claustrophobic investigation. It's an imaging, right? MRI is not a treatment. It's just a procedure to find out what is wrong so that they can go ahead and do the treatment. So when children have MRIs, it is very, very loud. It is very noisy, and you need the patient to lie very still for about half hour, 40 minutes. Now it's very difficult for an adult to lie down very still like that for half hour, 40 minutes. Sometimes the children are in pain when they lie down. Sometimes they just don't like the noise, and then they are children at the end of it, and it is very claustrophobic. You can't even put the child to sleep and take a sleeping child there because the noise is so loud that the child will wake up. So in these so MRI is one area where we use anesthesia. The other is for CTs. CTs are very small procedures, but that time also we need the child to lie very still. And there's radiation involved in a CT. MRI does not have radiation. CT involves radiation. So now if the child moves, you cannot, even though the CT will take you like all of a minute, the child moves, you cannot expose the child again to radiation. It's not safe. So to not go wrong, sometimes the children that will not cooperate may need anesthesia. There are other things called EEGs, electroencephalograms, and these audiology assessments and all that require anesthesia. These are done outside the operating room. So we still give anesthesia. There's not much of pain during these procedures. So there's a lot of sedation involved. So the drugs we give are different, but they need to lie very still for the procedure, and that requires anesthesia.
So what are the different types of anesthesia? Are there because you said you gave a different type of drug for different procedures.
Correct.
Are there multiple types of anesthesia?
There are many drugs. Okay. Yes, there are many drugs that we use in anesthesia. When we give anesthesia, we use different drugs. Like there's a certain drug that we use for the patient to fall asleep. There's a drug that you have to give for pain. Okay. There's a drug that you have to give for muscle relaxation. Now all these drugs come with side effects, and some of the drugs cause the patient to salivate a lot. So there is a drug we give to reduce the salivation because we don't want the saliva pooling in their mouth or going down the back of their throat while they're sleeping, right? Yes, so there are a lot of drugs, but when we do these imaging, like when we do NORA, most of these procedures are not painful. MRI is not painful, it's just loud. So when we do NORA for an MRI, then that time we don't give anything for pain. So we still give something for the patient to fall asleep, but we don't give anything for pain. So in that way it is different, yes. We have a lot of drugs. So all these will come under general anesthesia. Okay. Then of course there's regional anesthesia. You must have heard of spinal anesthesia, that's the most talked about. Yeah, you think that after spinal anesthesia you get a backache. No, it does not happen. That is another myth that needs to be busted. But these are called regional anesthesia. When you decide to block only a part of the body and not the whole body, you can be awake during the procedure with that part of your body numb. That is regional anesthesia. It can be from your lower half when spinal anesthesia is given. Spinal anesthesia is the term that the public use, but what we'd call it a subarachnoid block. There's a certain space in our spinal cord that is blocked that takes care of the sensation in the lower half of the body. Okay. Nowadays there are different types of subarachnoid blocks where you can take, there's loss of sensation can be provided in middle parts. Like in exactly the area which is operated. So when there's a surgery happening in the abdomen, you won't necessarily have heaviness of legs. We have an expert who does this in our team, Dr. Karthike Kambaram, who's brilliant with this and provides anesthesia for children in certain areas, which makes only those areas numb, and then the child is still able to move the legs.
Is that more about the quantity and where you give the anesthesia? How is the procedure?
Yeah, it's a type of drug. It's a type of surgery that is done. Some surgeries which involve a lot of intestines and everything, you cannot do that kind of thing. But yeah, it depends on the surgery. The drug that we use is slightly different from the drug that we'd use for the whole lower half to get anesthetized, and of course the quantity also. The dose will differ. We have to calculate the dose very carefully, especially in children, and we do different types of blocks like this.
Because you said that expert doctor is there.
Yes.
I am little curious about, is it not a standardized procedure like for every doctor to do the same, or is there a doctor who specializes or good with it?
So I'll tell you how. We all are trained to anesthetize the children, but each of us becomes my interest is in NORA. My interest is non-operating room anesthesia. So when there are MRIs lined up, I'm the one that goes. I like to go for these MRIs because I enjoy working with the children. I enjoy that getting them anesthetized at that plane. It's I won't say it's a specific specialty. You don't have to study to be this. This is an interest.
Okay.
So this other doctor who's with us, his interest is regional anesthesia. So he's very keen on improvising regional anesthesia. Now everybody is trained to do it.
Okay.
But I'll have to say that he's the one that pushed us all to get started with this.
Okay.
So yes, we have people who work with us in our team. Everybody in the team has something that is special about them. If you see that the children we start operating on children from day 0 of life, from when they are born.
Okay.
And there are very complex surgeries that are done at that age. And if you can imagine, if you have a child that is born preterm, if you have a 1.5 kilo child, imagine 1.5 kilos is slightly heavier than that bag of sugar in your house. But when you have a child of that size, and then you have to fix an IV line, and then you have to put a block for that child, and you have to give this kind of anesthesia, and then for the surgeon to operate on that small abdomen or whichever part they are operating on, it requires so much skill. We have one doctor who's particularly interested in neonates. Neonates are newborn babies.
Just newborns, yes.
Yeah. So all of us, some of us are significantly interested in heart and lung related anesthesia. So amongst us itself, we have people with different interests, but we are all trained to do the same thing. Yes.
Got it. Okay. And in general, the myth which I think during surgery, when I think my grandmother was in a surgery, is she has to respond and wake up. We have to wait till she wakes up. We don't know when she'll wake up. So it became a really scary situation till she wakes up. I was asking the doctor, he said, no, we've calculated and given the dosage, but still her body has to respond in her own way. Only then she'll wake up. Till then you have to wait. There was no specific timing for her to wake up. So is there a lot of risk involved, as he said, for people? We don't know how their body will respond with age or whatever ailments they have. Is there something very particular about anesthesia which people have to be, look out
worried
for?
about? Okay. So anesthesia for different age groups, the types of the drugs that we give are different.
Okay.
So for babies, the drugs that we give, for babies, we are worried about their heart rate going down or their pressures going down. So whatever drugs we give, the doses that we give are very minimal. It's minimal means it's based on their weight. But generally, otherwise, children and babies, they're healthy, most of them. Now, when it comes to older people, then by the time as you grow old, you have these other comorbids that come. There's diabetes, there's hypertension, there's cardiac issues, there are a whole bunch of other issues. So for those conditions, again, we have to titrate the drugs. We have to choose to not give certain drugs. Sometimes if you have a heart condition, we cannot give them drugs that will cause an increase in the heart rate because we don't want their heart to beat too fast. We want to maintain a certain heart rate. So we titrate the drugs and give it accordingly. Now you were telling me about people waking up after surgery. This doesn't usually happen, very, very, very rarely. But now when you say they're not waking up, it may be because they're not out of their muscle relaxant. Okay. Muscle relaxant is something we use to paralyze the patient during surgery. Now what happens when somebody is operating on the abdomen, the abdomen tone is very tight, so you need the abdomen muscles to be loose for you to be able to operate.
Okay.
And while you cannot just make the abdomen muscles loose, we end up paralyzing the entire patient. While the patient is paralyzed, we have to breathe for the patient. So when we say breathe for the patient, I mean connect them to a ventilator. So now when the patient is under anesthesia, each relaxant, there are different relaxants that we use, muscle relaxants. Each relaxant will act for a different period of time. So what we usually do is we time the relaxant and we give the dose based on the patient's weight. Now there are a lot of monitoring techniques you can do. There's something called a neuromuscular monitoring technique, where you put, like, there's an electrode that's stuck on the patient's skin, and you can see how the response is, and so you'll know earlier itself if the patient is coming out of anesthesia. That could be one of the reasons why there's delayed recovery, like how you said. The other reason could be sometimes they may start breathing, but they may not wake up as yet. That is when the plane of anesthesia is little deep, but usually they respond to a painful stimulus at that time, right? So some people will respond to call, and some people will respond to like a painful stimulus.
So they actually tried beating the hand.
So that time she was moving, but not.
She was.
So then she was. So as long as they are breathing properly and we know that they are comfortable, it's okay to wait for them to wake up naturally. You don't have to have them wake up and start a conversation with them after surgery. If they're breathing, their vitals are stable, and you know that the airway is safe, you can let them be and let them wake up on their own. Sometimes most of the anesthetic drugs will metabolize in about 2 to 3 hours maximum. But depending on the condition of the patient, say they have like a liver issue or they have kidney issues, then that time the drug tends to stay longer in their circulation, but not like worrisomely longer, just a little longer. So only when the patient is safe, we actually shift the patient outside the OR into the recovery room. We call it the post anesthesia care unit. So there again the patient is monitored with you use a monitor, there's a nurse, and the fluids are titrated. We wait till the patient fully wakes up, and then we can start feeding the patient 2 hours after the procedure, depending on the type of procedure that's done. It's different for different patients basically. This not waking up is not so common because of the advancements in like neuromuscular monitoring. So it's not really worrisome. No, I wouldn't be worried about it.
So in your career, you would have had some kind of a challenging or critical cases when it comes to this specific domain. So anything like that which you overcome, which you would like to talk about? Any challenges?
So there was a time, I have a keen interest in thoracic anesthesia as well. I had the opportunity of working with the Santoshams. The Santoshams are a group of chest doctors that operate. They have a clinic they have a hospital in Egmore. It's called the Santosham Chest Hospital. So a friend, I was working with, for a short period of time I was working there, but I was working with adults and I was giving anesthesia for adults at that time. So there was this one patient that I will never forget. We had I don't know, there's a procedure called bronchoscopy. Now bronchoscopy,
sending in that tube,
right?
Understanding
we want to see what is happening inside the lungs types. Now you can put a tube into the mouth and you can see what's happening in your stomach, right? Like that you can put a tube through the nostril or through the mouth and you can reach the lungs and you can see what's wrong. And then what they go ahead and do is, if there's a mistake, they fix it bronchoscopically also, which is like a real significant advancement. You're not cutting open the chest to do something like that. So we had a patient who had, we've got 2 lungs, right? Lungs are what we breathe with. Now we had a patient who had a tumor in one lung, and that tumor was, when I say tumor, I mean a swelling. It can, only after we take it out and biopsy it, we know if it's a cancer or not, if it's malignancy or not a malignancy, if it's a benign tumor or malignant. So what we were planning to do that day was, we were planning to take that biopsy, to take that sample, to cut that tumor out and take it again through the bronchoscope, with the bronchoscope. Now because this patient had this tumor, the lung beyond the tumor was completely collapsed. It was not functional. Right? And so we wanted to see what this thing was about, and so only the other lung was working. So the patient was breathing with one lung, which is significant in itself. Now what happened when we were doing the procedure, we went in, the surgeon went in and I had anesthetized the patient. He managed to to cut that tumor and to bring it out. It's very difficult. When I say it, it sounds so easy, right? It's very difficult to do that in that compromised space. He brings it out, and then the tumor slips, the swelling slips and falls into the other lung. Now at this point, there's one lung that is completely collapsed and not working, and then it has fallen and blocked this other only lung that is working. Right? So it was one scary, it was a very scary procedure for me. So what happens when the patient doesn't, now that lung only provides oxygen for the rest of your body. And the next step that happens is you will arrest, you will get a cardiac arrest. But when you get a cardiac arrest also, you can put an ET tube, you can do all that. But if you can't give oxygen, then what are you going to do? The whole point is oxygen. But this surgeon is a brilliant surgeon, Dr. Rajiv Santosham. So he went on and he managed to reach that tumor again, and again managed to pick it and managed to get out just in time. So the patient came out again. The only thing the patient said was she was feeling very hungry. It was a lady. She said she was feeling very hungry, but the stress that patient had put us through was something else. But yes, that is one procedure that I will never. It was with an adult. I will never forget. With children, we've had. Thank God, we've not had such dramatic procedures with children. It's been good. It's very nice. It's very interesting. It's very challenging working with children, but it also gives you this satisfaction. And so I don't have a dramatic story like that to tell you with the children.
Yeah, I
but
think
yes,
the trauma doctor goes through such procedures, what gets into their mind is much higher than the patient itself.
Absolutely.
Because when they are actually sleeping, the episode which happens is much more, like
True.
very close calls and
Their
things like
life, when we take up a person for a surgery, their life depends on us. Like the machine is ventilating them for whatever if reason the machine fails. I mean, we are responsible for the machine. I can never come out and say, you know what, everything went wrong because the machine was not working. It's my responsibility. If the machine is not working, it's my job to sort out the machine or to hand ventilate the patient or to figure it out there.
Yes.
Because when I take a patient in, I take the responsibility of keeping the patient safe. There are things that can go wrong with the patient. You know, the patient may have a cardiac arrest for whatever reason, and other things could go wrong. But yes, these technical errors that could happen and all these things. So we do a very thorough checkup before the surgery, because we make sure everything is working, and we make sure that we have spares. We make sure that we have extra hands, especially if it's a difficult case. We have a great team. It all works with the teams. If you're able to understand each other, then it's good, because when I talk to my technician, I need them to understand what I'm saying. I can't take a class while we start. And everything with anesthesia happens in minutes. The drug that you give will act immediately. Yeah. You cannot wait and say, where is this? You don't have that time. So we tend to be more irritable also as anesthetists. We're very difficult people to live with. You should ask my husband. But I think our job, to a large extent, makes us that way.
Got it. And one more question is, do you train to keep yourself cool because under situations like operations are one of the most terrific things which people actually, people will get scared. Immediate first thing is there any other solution apart from operating? That is the first thing a patient asks.
True.
Can it be done by injections or other things? No, you say you have to operate, there is no procedure. So you're always under the hammer when you're actually operating. It starts with you, the
Correct.
operation starts with you. So do you train your mind to actually stay calm in all situations? Because the story which you told was actually terrifying for the person who's operating than the person who's actually
the
in the
experience,
theatre.
correct, the patient, right?
Because those 10-15 minutes are going to be life changing for everybody in the room.
I don't mean 10-15 minutes also. I mean like a minute and a half, 2 minutes, 3 minutes, and you have to get it out. That was one. It was one.
So how do you keep your cool? Is there something?
No, we try as anesthetists. You have to we're prepared for the worst, right? So when we start off a procedure, we already have the drugs ready that are required during a cardiac arrest. We almost never use it, but we never say, since we never use it, so we have a defibrillator ready in the theatre. We have drugs ready for cardiac arrest, and everybody is trained to be able to use everything. Anesthetists work very closely with anesthesia technicians, so they also work with us, and they also help us. They know when we ask for certain equipment, like in an emergency, they're able to understand exactly what we're asking, and they make sure it's done. So we have a checklist. This checklist is what takes away that anxiety that could happen later. Now when you need to we know what drug to give, but what if you don't have the drug at that time? To avoid that, we make sure that the drugs are there. So we take time preparing the theatre, we take time preparing for whichever specific procedure, and we make sure we have everything. There are a lot of drugs that go to waste. We end up throwing a lot of drugs, but better safe than sorry. So we load the drugs that we need, that we might need for the procedure, or we keep it handy at least, and then we go ahead and do it. Specifically for stress, we know when it's a difficult case, we try and ask for an extra pair of hands to be there. We have colleagues, we work as a team. It's better when you work alone, that you can definitely make more money, but when you work as a team, the money is shared, but so is the stress. So you have an extra pair of hands. Sometimes you are not able to ventilate a patient, there's somebody to help you, you have a colleague. So it makes life easier for the anesthetist involved, it makes life safer for the patient, and at the end of it, it's a happy surgery.
And one more question on a little bit personal side is, does the human element interfere a lot in your career because you deal with children?
I think we get used to it. I don't want to say it like that. I mean, still when we see the parents, once the child is in the theatre, once the child is draped, right? Draped means covered everywhere, and the part that is operated alone is exposed. I personally don't even remember the face of the child during that time. I mean, I might have spent a lot of time with it. At that time, the only thing I can think of is, keeping the child safe, what type of drugs to give, and how to bring the child out of anesthesia safely. That is our only thought. We never, at least over the years, we've learned to keep emotions aside. It doesn't usually, we still don't operate on family. We don't anesthetize family. We don't encourage it also. If I have close family coming, I don't go and do the procedure. We have somebody else do it. But otherwise, to a large extent, I can say we've gotten used to it. We still care and everything, but it doesn't, hamper our judgment in the theatre. No, I think we've gone past that.
Okay. So, more on now we can talk a little bit about cerebral palsy, what it actually does to kids. People don't have awareness yet on what it is, autism, these kind of, because as I see, it is increasing in the amount of people affected by it, and though medications are still there, these are things which stay for a lifetime, and you just have to maintain it probably, and people don't even have awareness what it is.
Correct.
Because in probably India, especially in tier 3, tier 2 places, everything is called with one name, that they are mentally unstable.
Correct.
And they don't even go into the depth of understanding what exactly is the problem for the child. So you like to talk more about these things?
So first I must say that cerebral palsy has nothing to do with anesthesiology. It's a completely different thing. This conversation has nothing to do with me being a pediatric anesthesiologist, nothing. And the second thing I have to say is if I have to talk about cerebral palsy, this conversation can go on for days. It's not very definition. But the reason why I said that I was interested in cerebral palsy is because I have a child with cerebral palsy. I have a 13-year-old daughter, and she is wheelchair bound. So she was born, now the reason why I am telling you this is not for sympathy, but because because not many people understand that cerebral palsy can happen anywhere. Now cerebral palsy itself is it's a condition that involves the brain. It covers a very wide spectrum of diseases that involve the brain. Now it is something, if I have to tell you in plain terms, right, for you to understand, it's like a stroke. Now it could range, so if I have the loss of function of a finger, or if I have the loss of function of an entire arm, or the loss of function of all 4 limbs, or with all of my limbs moving properly, but still some tone related issues, all these will still fall under cerebral palsy, right? Now this is only with the physical issues. Mentation may or may not be affected. Speech may or may not be affected. Though you might think, speech is more of a sensory thing, speech has a motor component to it. To be able to understand is the sensory part, and to be able to talk is the motor part. So you see people who have children or adults who have issues talking. Sometimes they can't say certain specific words. All these could come under this broad spectrum called cerebral palsy. Now cerebral palsy is more common than you think it is. The classic cerebral palsy occurs in about 4 out of 1,000 children are born with cerebral palsy, but again you can develop cerebral palsy later. If you have a stroke as a child, you could end up as a person with cerebral palsy. If you have meningitis, which is like an infection of the brain, and a post meningitis, we call it post meningitic sequelae, and then at the end of it what the child suffers from is cerebral palsy. So you can so all these will come under cerebral palsy. Now cerebral palsy can affect any child in any family, either before, during or after birth. This is one message that not many people understand, that cerebral palsy does not look at your socioeconomic status. It does not look at the health of the mother. It does not look at these conditions and say, so this family has not been taking enough vitamin B12, so here's where I'm going to go.
So there's no specific root cause to it?
No. You can never say when a child will get cerebral palsy. You cannot diagnose cerebral palsy.
Okay.
There are some instances when you can say that yes, this child may be more prone to this, but mostly you won't be able to make a prenatal diagnosis, right? So the child is born, and while the child is born, sometimes there are compromises to oxygenation. That's why obstetricians are very stressed when the delivery is happening, because the child's life and the mother's life is dependent on them.
Okay.
They want the mother to be safe and they want the child to get enough oxygen while the child is coming out. For whatever reason, if oxygenation is compromised at that time, again that child could become a victim of cerebral palsy.
Oh, the oxygen doesn't reach the brain.
Yes, it happens when the oxygen doesn't. So oxygen means through the blood. So the blood supply to the brain is compromised, or the oxygen into the lungs to the blood then is compromised. That could cause cerebral palsy. So an ideal example of cerebral palsy is my situation. I had an uneventful pregnancy. I got pregnant when I was 26, and completely uneventful pregnancy. And given my height, at that time I was skinny, and given my height and everything, we were so sure I was going to have a normal delivery, and I didn't even take the pregnancy seriously because everything was good. And at 7 months, I suddenly started bleeding. I just bled. It was a painless bleed, and that day my husband happened to take off from work, so he was there at home, and we rushed to the hospital, and within 15 minutes of me rushing to the hospital, they had to operate and get my daughter out. So it was my mother-in-law had to operate on me. Usually we don't operate on family, but this was a situation where they could not even wait for another doctor to come. So my mother-in-law ended up operating on me. I had an emergency cesarean section, and my daughter was born when she was 7 months. She cried immediately after birth. That is something we look for, because we want to make sure enough oxygen is getting in. But somewhere between then and I don't know, later. So my daughter, her name is Anne. She's 13 now. She was shifted to the ICU, and she was electively ventilated. They put a tube down her throat because she could not breathe. She was too young to breathe. She weighed only 1.7 kilos. They weren't able to ventilate her properly. She could not breathe properly.
7 months is pretty early.
Now 7 months is not so early. Now we're able to take very good care of children that are born at 7 months. At that situation, at that time, it was a bit, I don't know what went wrong where, but when Anne celebrated her first birthday, her milestones, how you identify cerebral palsy is the children's milestones get delayed. So normally you expect a child to hold their neck, to be able to hold their head by 3 months.
Okay.
Everything gets delayed in cerebral palsy, right? So all this was happening with Anne. Then we found out that she had this issue, and we've been with physiotherapy since. And I have to tell you that it is one stressful journey. So when cerebral palsy actually happens in a house, it affects the child, it affects the parents, it affects the grandparents.
Yes.
Divorce rates are very great in houses with cerebral palsy, because the parents don't know how to deal with their situation, and then with the child with special needs.
Correct.
So awareness about cerebral palsy and what to do about cerebral palsy, and how to be sensitive towards cerebral palsy, I think will go a long way in making this a better place.
Okay. There are advancements which are being pushed in that domain right now.
The predominant treatment for cerebral palsy is physical therapy. Physical therapy could range, the child will need, from when cerebral palsy is diagnosed, the child will need physical therapy. Now we have rehabilitation here in Chennai. I used to take my daughter to the US from 2015, 2016 because of this one particular program that had shown like significant results in a couple of our friends. So we started going and doing this program. It's a neurodevelopmental therapy program. This is done by a group of neurodevelopmental therapists. Now this program uses the child and the child's body weight and certain techniques that helps the child get stronger, and hence what we try to do is we try to bring the child to close independence. You may not have a child, I don't know if my daughter will ever do ballet, but we're hoping that she will get up and walk, right? But for that you need the therapy. So now what you see regular children crawling and then getting up and walking because their brain already knows what to do. But in cerebral palsy, their brain does not know the pattern. So you have a 13-year-old still learning how to walk. They don't know how to lift their leg and take that step, and they don't know the pattern of walking. So yes, there's a lot of improvements now, but the only proven benefit comes from physical therapy. So I don't know if this is the appropriate place to say it, but with Apollo, I work with Apollo Children's Hospital. So we are doing this program with Apollo Hospitals. It's called Neurosculpt 25, where we are looking to bring that kind of therapy into Chennai. So this is the first of its kind course in South India. It's a neurodevelopmental therapy course. We have 4 therapists flying in from the US who are going to be coming and training our therapists to do this course and get an international certification. We also have 26 children who will be part of this course, who will be able to benefit from this kind of therapy. and we're hoping the message will reach people and people will know that life can be better. It does not have to be miserable.
Right.
The parents need a lot of support, the children need a lot of support. The government of Chennai has stepped up, of Tamil Nadu has stepped up significantly, and there are so many measures that the government is doing now to make life for children with cerebral palsy better.
Oh, okay.
We still have a very long way to go. I can't take my child to the cinema, I can't take her to the beach, but why should it be like that, right?
Right.
I can have an accident today and then be wheelchair bound, but does that mean I can't go to the beach? I like to go out, I would like to go for a drive, but to think that if I have an accident and if I have an injury to my leg, I will be stuck at home is a very difficult situation to accept. So we have to work on therapy, yes, but we also have to work on accessibility.
Right.
When people understand that accessibility is not only for people with conditions that they are born with, that everybody needs accessibility. You could need it at any point in your life.
Any particular message you would like to give to aspiring people who want to get into pediatric anesthesiology?
Pediatric anesthesiology itself is a very niche field. It is a very satisfying field. It has just the right amount of adrenaline and satisfaction. So what makes it different from working with adults is the children trust you. You work with children and they trust you and they believe you when you say that there won't be pain, and if you manage to take them through that surgical journey, it's just the smile, it's just that acknowledgement that they give you at the end of it, which gives us the satisfaction that we worked for all day. Monetarily, I won't say it's the most rewarding field, but the satisfaction that it gives you to have made a difference in a child's life is what is very rewarding.
And anything you would like to tell the people watching this from your perspective?
About pediatric anesthesia?
About pediatrics in general or medicine in general. The myth you would like to bust, or people should be aware of this thing.
No, awareness wise, I would want to talk only predominantly about cerebral palsy, about accessibility. Awareness is this one other thing I think I should mention. Cerebral palsy will include diseases that you can see, right? Like when you have a stroke or you have a child that cannot walk. Then again, there's this broad spectrum called autism, yes. And there's a lot of overlap with cerebral palsy and autism. And then you have for children with autism, the child looks okay to you, but the child's behavior is off. So the only thing I'd like to say is that when you see a child behaving inappropriately or you see a child behaving badly, do not be quick to judge, because there might be so many things happening with that child, with what is happening in that child's head, what is happening in the child's family, that may be affecting that child's behavior. Some types of cerebral palsy are not visible. Lots of grades of autism again are not visible. So just to not be quick to judge itself, I think will make a big difference.
Are there tests to find out different scales of autism? Because I even read a lot of people are autistic, but outside world doesn't even see them as autistic people because they themselves don't know that they are autistic. There are issues like that.
Autism is a big spectrum, like cerebral palsy. Autism is also a very wide spectrum, and there is a lot of overlap with cerebral palsy and autism. So it works like this. You have there's the brain. Different parts of your brain, some parts are in charge of your muscle, your motor functions. When I say let me say movement. Some parts of your brain are in charge of the movement, and then some for pain sensation, and some for vibratory sense, and some for emotions. There are different parts of your brain. If you watch the movie Inside Out, it will teach you half the neurology you need to know. But when you have issues which involve again, it's the oxygenation that has happened at some point. So to find out if there's something, whichever part of the brain has been affected, there is MRI imaging, but you can have a completely normal MRI, but your child could still have cerebral palsy and autism. So this kind of imaging won't show you cerebral palsy or autism. You cannot look at an MRI and say this MRI is normal, so this child is normal. It does not work like that. Most of the cerebral palsy and autistic children have normal MRIs. MRI brain is the only imaging that can be done. There are a lot of scoring systems that can be done for children, which will evaluate and tell us if the child falls within that spectrum. And when there are a lot of questions that the therapist will ask the child. There are certain simple puzzles that the therapist will give the child to complete, which will tell us if the child falls on the spectrum or not. Now, if we were to evaluate you and me also, I'd probably be on the spectrum. But you never know, we never really had that evaluation at that time, right? But yes, there are evaluations that are done that will be able to say if you are on the spectrum or not on the spectrum. Then there's learning disabilities, there's dyslexia, there's a whole bunch of other behavioral issues and different parts of autism. But those are all, they're all different topics. So you could have many issues related to behavior, most of which can be evaluated with this kind of, this certain questionnaire that the child has to do. Now for that you have to have the child to be able to understand it.
Yes.
So it's not always very possible. If you have, so ADHD, you must have heard of ADHD.
Yes, yes.
Everybody is talking about ADHD. We have fidgety adults who we think have ADHD. Now, if an ADHD child will be able to sit through an entire assessment, the time of that assessment to see if the child is falling on the spectrum itself is a challenge for the child. Right. But yes, there are assessments available, but it's not through imaging. No, you can't have it in black and white saying that, you know what, this is 100% this, you can't say it. There's a lot of gray areas, which is why excellent therapy and excellent therapists are very important. The only change that can happen will be with good therapy and good therapists. It is very important if you see that your child is having issues. First, it's very difficult for the parent to accept. Sometimes you just dismiss the child as a badly behaved child, or you say that, ever since the second sibling was born, this child has been behaving off.
Right.
But the child may have an inherent problem. So it makes sense for the parent to take the child to the pediatrician and then to a therapist and explain the problem, and not just look at the child as a stubborn child or a child that cannot learn or a child that cannot understand. So if you accept that the child may just have a problem, and if you take that initiative and try and evaluate it, then yes, you can identify conditions early. The advantage of identifying it early is you can start therapy early. But for the therapy to be successful, you have to have a good therapist. To have a good therapist, I'd recommend that you attend Neurosculpt 25.
Okay.
But no, apart from that, you have some excellent therapists that have not done neurodevelopmental therapy. But it is important to find a good therapist, and not just any therapist, right? Okay. If you make that effort and find a good therapist, you'll be able to make a big difference in the child's outcome. Significant difference.
Are there any significant symptoms which actually the parent can see in their children? Because a lot of people don't know what symptom to look for also. If it's a 2-year-old or 3-year-old, as you say, they just dismiss it saying this is a normal behavior. But actually, are there any specific hospitals or tests which parents can actually take in advance to actually figure out whether the 2-year-old or 3-year-old, what is the right age for actually parents to take tests for their children, and what is the type of test, where should they go? No awareness is there when it comes to this specific domain.
Correct. So you can there's no specific age. You can pick it really early. If there are parents who are really observant, you can pick it really early. Many times the parent may be wrong. Sometimes the parent may be overcautious. Maybe that's what. Yeah. But it's better to be overcautious than to be like wrong. Correct. Later. So if you see the child have any let's say temper tantrums that are a little more than usual, right, which happen very frequently, or if you see the child having any having difficulty focusing, if the child can't look at you and have a conversation with you, the child keeps looking away, if you have a difficulty, or if you see the child doing any kind of repetitive movements, or if you see drooling, if you see the child drooling, or if you see that something is off with the neck control, or if you see that the child has specific writing issues, like children who tend to do the P and the D in the opposite directions. We've all gone through it. Most of the time it's okay, but it's worth the evaluation if it doesn't settle. Every child will muff up the B and the D, but how long is the child taking? If you find that when you talk to your child is not really able to follow orders, if you find that the child seems like unnaturally forgetful, all these issues you can talk about to your pediatrician, instead of just saying that, this is one lazy child who doesn't listen to anything, this child is not going to go through school, this child is a failure in class. When I think back about my school days, and when I think about some of my classmates that have always been branded as, this is the dullest girl in this class type of thing, maybe they had issues, right? Maybe with some occupational therapy with the right kind of therapy, maybe life would have been different for them.
True.
So, so if you find anything repetitive or anything that you have the slightest doubt about, it is best to take that issue to your pediatrician, who will be able to refer you to a therapist, and you can have the therapist do the evaluation. Some developmental pediatricians itself do evaluations. They are excellent contacts to have. You can ask your regular pediatrician to refer you to a developmental pediatrician, and they can help you with evaluating the child. But yes, it's better to take a child and go and finish that evaluation and have them say, you know what, your child is not on the spectrum, don't worry about it, instead of just letting it go. But it's a very, very taboo subject at home to accept that your child may have a problem. Yeah.
Yes.
So we have parents, and especially here there are grandparents that live with us who don't want to accept the fact. Sometimes there's a disability like glaring in your face, but they don't want to accept it.
Right.
It took me so long to accept my child with a physical disability, right? Because I kept telling, no, you know, she's preterm and that is why this issue. Maybe there's nothing wrong, but it takes time.
Right.
But support makes a lot of difference. We're trying to come up with the government is actually trying to do these programs where parents will be able to be supportive of each other. Now, Aporo is also looking to start an exclusive pediatric rehab center to encourage psychological support, occupational therapy, psychiatric support. The psychological and psychiatric support being for the parents and the children and the families, right? Because when we have all that support, when we know that there are other people that go through the same thing as us, and now instead of me running around and it took me like 6 years to find a handwriting teacher that will be able to sit with my child with special needs and train her. Now when I meet a new mom, I can just give the contact, right?
Yes.
They don't have to go through 6 years of searching.
Correct.
So that kind of support groups will make a big difference. And to know that, I mean, like even between in the marriage also, right, with the spouse, having both of them, it becomes very stressful because the mother cannot go to work and the father has to work for the entire family. And this is not a, you know, an appendectomy, you operate and you're done with it. If you have whatever else procedure, this is an almost lifelong thing. Yeah, you have to see your child grow. You will see that the child is not able to participate in school. Very few schools are truly inclusive.
Correct.
So that's a hassle. You will see your child not be able to go and participate in a school excursion. So there are a lot of these hassles that that make, and then the parents, their other worry is, you know, what after us? So who's going to look after this child? So it should not be like that, right? And I think as human beings, we owe that responsibility to the community. We're not going to take, you know, we're not. It's not to gain brownie points, but if you can make a difference to another child, if you can offer that support, if you can hold the door open for a child with a wheelchair and another with a wheelchair, if you can step aside in an elevator and allow somebody with a wheelchair to pass, those are the small gestures that show our support, right? You don't have to support monetarily.
Absolutely.
But in these little ways, I think you can make a lot of difference. Yeah,
Great.
that's about it.
Yes.